yoga, and our minds are hopefully calmer and our backs are straighter. So today, as we move from mindfulness to fetal medicine, from flexibility to the from flexibility of the body to flexibility of thinking, and from wellness to cutting edge science, we are fortunate enough to have some of the finest experts with us who continue to push boundaries of prenatal diagnosis and fetal care. So with any further delay, let us begin our scientific session. So for talk number 1, we have Dr. Rajat Kumar Ray, sir. Sir, let me introduce sir. So sir has been, just a second. So sir has been the president of Indian Federation of Ultrasound and Biology, state president ESAR, professor and HOD of High Tech Medical College, Rourkela, and past president Foxy. So sir, please welcome on stage. Sorry, okay, Vice President. So, sir, please welcome on stage. Sir, the stage is yours. Thank you.
At the outset, I thank Dr. Munjal and Dr. Arati for inviting me and giving me this opportunity and to be associated with AOGS, IFUMB, to be associated with AOGS. Thank you. And my dear friend Prasant is also there. Prasant, Dr. Janak, Dr. Mayank, and all the friends are there. So I will be taking you 11 to 14 scan beyond NT. I bring greetings from land of Lord Jagannath, Odisha. So over 3 decades ago, NT scan was started solely for the Down syndrome screening. But now it goes far beyond Down syndrome screening because it is the time when a detailed first time anomaly scan can be done to most of the major defects. So according to the ISO guidelines, there is a long list. We will go cover all of them. Purpose for this scan to know the viability, gestational age, number of fetuses, assess chronicity, amnioticity, if a multiple pregnancy, and detect gross fetal anomalies, and of course first time unemployed screening time the NT, which we will not cover because we are not going for. And we start with viability. Obviously, you see the baby moving and the fetal cardiac activity, fetal biometry. First trimester, you do a proper CRL. So the proper, it should be like an NT scan. The CRL should be proper so that you get most of the informations and you also measure the accurate dating. And along with that, you do with the midline sagittal scan, ideally with the fetus oriented horizontally, magnified, neutral position, amniotic fluid should be visible between fetal chin and chest, end points of crown and drum should be defined clearly as in this picture. So along with that, we take all the 4 measurements what we do in second trimester, BPD, SC, SC, FL, because by doing that, we are looking at, we are excluding some anomalies in every section. So I am not going to the how we are doing it because everybody know how it is done in the second trimester. The same principle applies in the first trimester also. Then if you see a number of fetus chronicity, if you are seeing a twin pregnancy, multiple pregnancy, you must assess the chronicity because it is the best time to assess chronicity, and prognosis depends upon the chronicity. If we must first see whether there is a dividing membrane or not. If the dividing membrane is present, whether it is a T sign like a monochorionic pregnancy or it is a lambda sign like a twin peak sign in a dichorionic pregnancy. Anatomy, coming to anatomy, we will go cover one by one. Head and brain, we see in the head, we will see the calcification of the cranium. Contour shape, there should be no bony defects throughout. 2 brain halves separated by the intrahemispheric falx and symmetrical. And if you see the supratentorial region, little up, you see the coronal plexus filling most of the ventricles at this stage, giving a what we call as a butterfly sign. And from that, you also know the amount of fluid around that coronal plexus. And a lower plane within the head shows 2 thalami and the posterior fossa region with the cerebral peduncles and the aqueduct of Sylvius. You can see the aqueduct of Sylvius little bit lower. And if you mark from thalami to cerebral peduncles, it is converging. Whereas and there is some gap between the aqueduct salvius and occipital bone, cerebral peduncles and the occipital bone. There should be gap, some gap. If it is there, the gap is reduced, it is an indirect sign of an open neural tube defect, so that the midbrain is pushed posteriorly, cerebral peduncle cell pushed posteriorly to compress the midbrain. The fourth ventricle and the future cisterna magna are seen as a fluid-filled structures. Fourth ventricle and future cisterna magna, they are seen as a fluid-filled structures. And if there is a open spinal bipeda or open neural defect, it has been pushed to the almost touching the occiput, is known as a car crash sign. And another feature is that biped by SC is less than 10 centile, the head is long, and in this session also you can see a enlarged fourth ventricle at this stage, and this is a posterior fossa cyst. We can assess the posterior fossa at this stage also in first trimester. And if you see the choroidal plexus length to the ventricle length, there is a relation. It normally is 0.8 to 0.9. If there is the choroidal plexus is smaller, if it is around 0.6 to 0.7, it indirectly tells that there is ventriculomegaly, and if it is less than 0.5, it is considered as severe ventriculomegaly. And you see in this picture, you see the choroid, you can expect ventriculomegaly at this stage also. And you see the contour of the head, there is some projection coming outside, it is a encephalocele, but if there is small encephalocele, you should be sure you are not considering a yolk sac which remains by the side. So you must exclude if it is a yolk sac, you must confirm that. And this is a holoprosencephaly. Again, there is fused thalami and continuous of the ventricles. And this is a case of acronia. All these things, neural things you can see in the first trimester. There is no calvarium here. And then coming to mid-sagittal plane, of which is a anti-scan plane. You assess the posterior fossa and visualize the intracranial translucence of the fourth ventricle and the brainstem. So this is the typical NT section. I am not going how it is taken. Already it is covered. So in this you see three spaces. This is a brainstem. Posterior aspect of the brainstem is the echogenic. This is the fourth ventricle. This is the choroid plexus of the fourth ventricle. Behind that cisterna magna. So there are three spaces, and behind that this is knuckle translucency. So all this, if you see this area, this is brainstem width is always less than the brainstem to occipital bone width. It is less always. So if there is a discrepancy, it indirectly tells about the posterior fossa problems. Like you can see, this is increased GNT. Increased GNT is not only a marker for Down syndrome, but once there is increased GNT, there are incidents of major defects also increase along with that. And this is known as a BS by BSOB ratio. What I was telling you, this is brainstem width by brainstem to occipital bone width. It is usually less than 1. If it is more than that, like here, if it is compressed, it is again a sign of open neural tube defect. This fourth ventricle is otherwise known as a intracranial translucency, and otherwise it can be compressed. This is another posterior fossa abnormality. And if you draw a line along the superior surface of the maxillar bone, that line usually is below this the breaking point of between brainstem and the diencephalon. This point is always above that, but if it comes below that point, that big point, again it is a sign of open neural tube defect. Corpus callosum, cerebellum are not sufficiently developed to allow accurate assessment at this stage, so you should not try to assess those stage. Then coming to face and neck, you will look for the fetal profile, you look for the forehead, nose, lips and chin. Should neither be flat nor show any protruding structures at this stage. And you can see on the maxilla, the mandible and mouth and nasal bone. At this stage, you can see the forehead also. Another thing is known as a superimposed line. It is due to bone marrow. If it is absent, it is an indirect sign that it may be a cleft palate. And there is a maxillary gap also. If it is there is gap in the maxilla, it is another sign of cleft palate. And axial coronal view, you can see the eyes with the lenses also you can see with good resolution machines, and you know the interorbital distances. From that you know whether it is hypotelorism, and roughly you can put one eye in between two orbits. This is mid-coronal plane. This is known as the retronasal triangle. The base is formed by the premaxilla, and if it is deficient, then the apex is formed by nasal bone. If it is deficient like this, it is again a sign of cleft palate. And lips also, you can see with good resolution, you can see the lips also. And neck, there's a proper alignment of the neck with the trunk. Identification of other fluid collections such as hygromas or jugular lymph sacs should be noted. Thorax, you look for the shape of the thoracic wall, long fields and diaphragmatic continuity. The shape of the thoracic wall should be continuous with the abdominal wall. There should be no undue projection or scapules of the abdomen. It is a continuous thing. And you see the stomach is, you see the diaphragm on both the left side and right side, and stomach is always below and the heart is above, and the liver is also below. You see in coronal sections and sagittal sections. Lungs, they appear as homogeneous echogenicity without evidence of pleural effusions or cystic or solid masses. Heart occupies almost 1/3, and both the lungs 1/3 each. Heart, you according to guidelines, you look for the heart activity present with the regular heart rhythm, establish situs, position, interthoracic heart position on the cardiac axis to the left, size 1/3 of the cardiac thoracic space, 4-chamber view, left ventricular outflow, 3-vessel trachea view, and absence of tricuspid regurgitation and antegrade ductus venosus AOM. So 4-chamber heart, to start the situs, you must determine the situs beforehand, knowing the stomach is on the left side, and the apex of the heart should be always toward the side of the stomach. And cardiac position is, if they like this, the stomach and the apex of the heart should be same size. Cardiac position is always, heart is towards the left. If you draw one line from the midline of the thorax to the spine and another line to the interventricular septum, this angle is known as the axis of the heart. It is around 30 to 60 degrees, and it is always towards the left. So in the first trimester, the axis deviation is a major marker for any cardiac anomaly. Color Doppler, in first trimester, color Doppler is a must for the evaluation of cardiac. Color Doppler helps to confirm the presence of two distinct ventricles with separate filling in diastole and to exclude significant atrioventricular valve regurgitation. So you see there are two separate ventricles and they are filling separately. Great vessels, you look for the LVOT and 3-VT with color and Doppler demonstrations to know the presence of the two outflow tracts, number and size of the great vessels, their anatomic relationship to each other, the direction of the blood flow, and the continuity of the ductal and aortic arches. So you see in 2D also you can see LVOT, and you can see the crisscross, the RVOT and LVOT as crisscrossing on color Doppler. So in real time you will see that. Again 3-vessel trachea view, it is like line and ball appearance. So, and it is there, the direction of flow is same in both the arches. So and this is a abnormal thing. This looks like a B and this looks like UK, the right aortic arch. Ductus venosus, again you see if there is, if the AOM is either absent or reversed, again it is a diagnostic of cardiac disease. And tricuspid regurgitation, there should be no tricuspid regurgitation. This flow should not go beyond the 60 centimeter per second. If there is a normal physiological mild regurgitation, that is normal, but it should not go beyond the 60. Diaphragm, look for the continuity again. Intra-abdominal position of the stomach and liver you confirm. You can see in sagittal, see the both sides, on the left side and right side. See the stomach and liver below. And in this case, you can see stomach and heart are in the same plane. a diaphragmatic hernia. Abdomen, stomach, you should look for the normal position in the left upper abdomen. Bladder is normally filled in the pelvis, longitudinal diameter is less than 7. Stomach and bladder are the only hypoechoic fluid structures seen in the abdomen during this 11 to 14 week scan. If you are seeing extra cystic spaces, then it is pathological. And look for the cytos, as I have already told you. Kidneys, they look like bean-shaped, slightly echogenic structures with typical hypoechoic central renal pelvis. This is the diagnosis of kidney. And you see the pelvis is dilated here. And by 12 weeks gestation, you must see the bladder, and the longitudinal diameter should be less than 7 millimeters at this stage. If it is more than that, it is pathological. So, abdominal wall cord insertion should be documented after 12 weeks. There should be no midgut herniation, because physiological midgut herniation occurs up to 11 weeks. You can see the cord is directly entering the abdomen in the you look for both in the sagittal and the transverse sections. Here there is a limb body wall complex, the abdominal wall is deficient, and here this is a omphalocele and this is a gastroschisis. Intestines are projecting outside at the cord insertion side. This is the organs herniating into the base of the cord. Umbilical cord, you can look for the cord insertion and look for the number of vessels. Best is to see this by the side of the bladder. If you are seeing 2 vessels, again it is a 3 vessel cord. Placental insertion also you see to rule out any velamentous insertion, marginal insertion, and there you may come across some umbilical cord cyst at this time, but these are physiological, you do not worry. Spine, regular shape and continuity of the spine should be documented. You should see the regular, you should see both in longitudinal axial views, normal vertebral alignment and integrity, and you look for the integrity of the skin in the real time. There should be, the skin should be integrated. There should be no deficiency in the skin behind the spine. And you can see another, there is a spinal deformity. Extremities, upper limbs with 3 segments and free movement, lower limbs with 3 segments, free movements. Every limb you must see all the 3 segments, proximal, middle and distal segment, and in every limb you must see 3 long bones. So presence of each bony segment of the upper and lower limbs, presence and normal orientation of the 2 hands and feet, and terminal phalanges of the hands may be visible at 11 weeks. So this first trimester is the best time to evaluate the fingers, because the baby keeps its fingers open most of the times. So you can count the fingers and rule out any finger anomaly. And on the lower limb also, you look for all the 3 long bones and the relation of the foot to the middle portion of the legs. To rule out any club foot talipos, you can see the foot, even at this stage you can see the foot rotated. At this stage you can even see. Placenta, you look for the size and texture normal without any cystic appearance. Location in relation to cervix and to previous uterine scar and cord insertion into placenta, you must see. The ecotexture of the placenta should be evaluated. Abnormal findings such as masses, single or multiple cystic spaces, or a large subchorionic fluid collection more than 5 centimeters should be noted and followed up. The presence or absence of a subchorionic hematoma should be assessed. Prediction of the final placental location in relation to the internal cervical os can be challenging in the first trimester, because in 50% cases placenta is low lying here, but you should not comment it is a low lying placenta only if it is almost covering the internal os, or the previous cesarean section and it is a anterior low lying placenta. You must be careful for subsequent development of the placenta accreta spectrum. So this is a complete placenta completely covering the internal os. Then look for the amniotic fluid and membranes. The amniotic fluid, the change in the amniotic fluid volume either is a more or less is rarely observed in early gestation. So unlike in the second trimester scan, this cannot be used as a hint for any anomaly. The amniotic membranes are often well visualized as sacs around the fetus not yet fused with the chorion. When there is history of bleeding, a blood clot is often identified in the retroamniotic space. But what is more important, at this time there is a physiological separation between the amniote and chorion. You should be aware of that. You should not think that it is a subchorionic hemorrhage, unless the patients will be in panic. Gynecological pathology, both benign and malignant, if are coming across, you must note it. And it should be surveyed for abnormalities and masses. And any uterine anomaly is best seen at this stage, because as the baby grows, any septate or mild bicornuate uterus, you may not be able to identify as the baby grows. Screening for preeclampsia, this is the best time to screen for preeclampsia by taking uterine nitrate PI as an ultrasound marker and other maternal factors. And the screening for preeclampsia is based on a 11 to 14 weeks. To conclude, I say the scope of NT scan includes early detection and exclusion of many major anomalies. Early detection of anomalies allows longer times for genetic analysis or fetal treatment planning, easier pregnancy termination if appropriate, and the absence of fetal anomalies in first terms of at-risk mothers is reassuring, reducing maternal anxiety. But one thing important is, if you do a first term anomaly scan, you must also do a second term anomaly scan, because some structure develop afterwards and some may be missed in the first term anomaly scan. Before concluding, as a president of IFUMB, I invite you all to SCON 2026, that is the annual conference of IFUMB happening at Indore on 23rd to 25th October. And please block your dates for World Congress of Ultrasound, that is AOGS in 2029, happening at Mumbai. This is happening after a long period in India. So please block your dates for the 2029. Thank you for a patient hearing.
The insightful talk. Can we have Dr. Prashant Acharya sir to present sir with a memento, please? Glimpse into fetal development, the second trimester remains our most detailed opportunity to evaluate fetal anatomy comprehensively. And that brings us to our next topic by Dr. Mayank Chaudhary sir. So Mayank Chaudhary sir he has been trained at Mediscan Chennai. He is a leading fetal medicine expert at Mayflower Women's Hospital, and he is a top winner of COW Cow at fetus.net from 2013 till 2024. He has special interest in twin gestation, fetal growth disorder, fetal echo, and early pregnancy disorder. His novel idea for intrauterine transfusion for fetal anemia. Sir, the stage is yours.
And this is Marakasan. And these are the baby seen just in last 2 days. Jibrasan, Bagasan, and Alasan, whatever you tell that. And when there is a asan, there is a pranayam also. And you can see this baby doing Kapal Bhati or Basrika, whatever it is. So you can see from that, this all are from last 2 days. So this vibes of yoga day is going inside also. So topic is very wide, and it is a 10 days conference on this topic. I have to cover this in 20 minutes. Topic is TIFA scan, standardization, soft marker, and reporting pulse. And whenever there is this topic, we can convert this mid-trimester protocol, screening, and documentation. Good morning to all. Thanks to AOGS, thanks to Munjal Pandya for inviting me for this talk. I am very happy that Dr. Rajat Rai is also there with us. And typically, TIFA scan is ordered between 18 to 22 weeks. Regards from Mayflower Hospital and my team. And these are the 90s and 80s baby who are doing yoga. I will show you the millennia baby and Gen Z baby also in a different yoga posture. So agenda is let us go to our first agenda, that is a standardization, that is a protocol based scan. and in a given time, I can touch only philosophical part of this talk. I cannot go in a great detail of this. And I may make some statement which is difficult to palate or understand. We can elaborate that at a later time. So there are various guidelines, standardization to see the fetus across the gestation, and more or less all are good. And whenever we start our practice after 6 months or 1 year or training or whatever it is, there is some starting point. And these guidelines are our starting point. That is what you are going to achieve minimum. And then there is a FOMO factor, fear of missing out, because your friend is doing that. That's why you have to do that. So that 1 or 2 things will be added. And there will be a slap from the fetus every 6 months or 1 year. And वो थप्पड़ की गूंज बहुत सुनाई देती है. And due to that slap, you will add something in your protocol that I do not want this slap again. And there will be a peer pressure also. Corpus callosum, બધામ જોવાનું. Okay. વર્મિસ બધામ જોવાનું. અરસા ચાલુ કરી દીધું તે જોવાનું. So over the time, the few things are added like this peer pressure, which is actually not in a guideline. So I will very briefly touch rule of 3 from Mediscan Chennai. In that, there is a 7 step to follow. There are 3 anatomical plane which we have to see in each area, and 3 minimum thing to look in that. And outer limit of normal is 10. 7 plus 3 is equal to 10. This is a rule of thumb, and this is not a final verdict. Wherever you are in a doubt, you should follow the nomograms, but this is just a rule of thumb, like ventricle 10 millimeter, cisterna magna 10 millimeter, PCS dilatation 10 millimeter, outer limit. So what are those 7 steps? As in each and every branch, the first will start with a history, then with a survey that is called a Sihavlokan. Anyhow, you are going to apply jelly on the abdomen. You will apply jelly left, right, up, down. And during that process, that is called a survey scan, you are going to notice something. There is a list of things which you will able to achieve. Then we will go to the biometry, targeted scan, activity, environment, and at the end, reporting. In a cooperative baby, there are 36 approximately section. If baby is cooperative, in a 20 minutes, you will able to achieve that. History is very important to correlate the baby growth is according to gestation, to ask specific history, and there is a point to highlight, and you will see particularly, you will focus in your scan in that area. That's why history is important. It will break a thought cycle of previous scan. Otherwise, you will think that you have seen the hand already, and then in a follow-up another scan, you will miss the hand. You assume that you have seen the hand. So asking a history will break your thought cycle of a previous scan, and it will create a rapport with the patient. Patient will not feel the things are going in a mechanical way. लिया, स्कैन किया, रिपोर्ट दिया, बाहर निकाल दिया, ऐसा नहीं. And by any means, you can keep the scan room mood light, and I usually play music because sound and ultrasound go together. It will keep the tone of abdomen very light, so the scan will become easy. What we are able to achieve in a survey, global anatomy, in experience eye, you will able to catch up anomaly sometime. How many fetus are there, they are viable or not, what is the lie of that fetus, location of placenta is subjective assessment of a liker. Basic biometry is a BPD, OFD, AC, FL. There is a big list also which I am not going to tell you today, but just to explain the philosophy of rule of 3. The pregnancy is divided in a fetus, placenta and liquor and a uterus. We have to see this. The fetus is divided in a head, torso, and the limbs, and so on. So it is not that each and every section, maybe you are experienced, so you will put a probe and you are going to get a section. It is not like that. There is a movement from one section to another section. And in that process, either the finding may be at the section or in between the section. So this thing also you have to remember. And suppose there is a CNS finding, then you have to go in a targeted manner. You have to see many more things. Suppose there is a CVS finding, then again in CVS also there is more thing to see. So that is not included in basic guideline, but point I want to highlight is that whenever you find something abnormal in that system, you have to see that system in a great detail. The advantage of following protocol or standardization is from day one you reach as 95th centile at par with an experienced person, perform better than experienced person in a given case. If you have followed the protocol and experienced person has not followed the protocol, you will perform better in a given case. It is not a medical legal document, but has definite weightage when the things are in court, because they will refer some guideline. There is a list, checklist, so at the end of scan, you will feel that scan is complete, and it will give you confidence, and patient both improves the accuracy, facilitation of training and audit also, and it enhances the diagnostic accuracy and reduce human error, and optimize clinical outcome, and at the end of day you will feel peace of mind that you have seen as per protocol and not miss the thing. So these are the millennia baby in a different yoga position. Going to our second agenda, that is a soft marker or a screening. So before 150 years, Longdon Down make a statement: the skin is deficient in elasticity, giving the appearance of being too large for the body. The face is flat and the nose is small. So in first trimester, in second trimester also, these are the main observation as a marker: anossified nasal bone, hypoplastic nasal bone, increased nuchal skin pole thickness. There are other things also in this, but this till date, since so many years, this has become a robust tool. Screening is a test, not necessarily diagnostic, which identify a subgroup which are at higher risk than primary cohort. This subgroup need further evaluation, which may be time consuming, expensive or invasive. At the end of screening, you are going to achieve, you will get a high risk and low risk population. Low risk does not mean zero risk. This thing you have to understand. In high risk, again, there will be a false positive and true positive. In low risk, there will be a false negative and true negative. One thing is fundamental: the screening tests are not 100% accurate. Even NIPT 99.7, some quote 99.9, but they are not 100%. So there are various tests available. When we started our practice, at that time, NIPT was just in a lecture, in PPT only. Then it was introduced at 42,000 price, and now everybody can afford. It has reached to the affordable limit, and the book of screening is now rewritten, because previously everything was evolving around double marker and sonography, first trimester, second trimester, and the NIPT has changed the game, and NIPT has rewritten the book of screening, and cost has also come down very much. But when there is a major defect, don't do screening. You have to bypass the screening and you have to go to confirmatory test after invasive testing. Patient has a right to opt in or opt out, and he can exit at any point of time. Can decline screening, can decline invasive test, and can decline scan also. So this is 2013 document which we are following, and you can see here ventriculomegaly, nuchal skin pole thickness, ursa and nasal bone is on top highest likelihood ratio when they are as a isolated marker. But at the same time, you have to reassure the parent that probability of non-Downs baby at even at 40 years of age is nearly 99%. Test is not going to harm baby or mother. Even patient is not ready for the screening, scan is must, this thing you have to highlight. And with abnormal invasive test, parent will need one more session of counseling. And this is as a part of extension of reporting. At the end of scan, whatever you have conveyed the patient and whatever patient has understood or accepted, that you have to add. And this is going to protect you. That's why I have offered the test, but patient declined. I have offered the so and so test, and patient has accepted this test. That is in first trimester, second trimester. So I add this line at the end of a report, whatever the patient accept. Please remember, NIPT is not a diagnostic test which is marketed like that, and confirmatory invasive testing is required in the presence of any abnormal result. NIPT has not been evaluated extensively in a low risk population, and positive predictive value is low as compared to high risk population. First trimester risk or double marker risk is irrelevant when you have a NIPT result in your hand. And in intermediate group risk patient in a double marker, you can discuss option of NIPT to them. And this is very important thing that no genetic sonogram, which include looking for soft marker of trisomy 21, should be performed in a woman where the NIPT report is normal. And when NIPT is positive, in that case, amniocentesis is preferred over CVS as far as possible. So the fundamental of soft marker screening is all rise NT are not Downs, and all Downs do not have a rise NT. Role of NIPT in very high risk and low risk need validation. In structural anomaly fetus, in 6 to 7% of case, you will show some abnormal microarray report when the karyotype report is normal. So when there is a structural abnormality, please bypass the screening. No termination on the basis of NIPT report. And apart from trisomy 21, 18, 13, all other information need validation, and that is a marketing gimmick from the sonography company. These are the Zen Z, various yoga posture. So coming to the last agenda, reporting PUL. Findings are more important than diagnosis. Do not take a burden of diagnosis. Your finding should be perfect. Describe lesion size, appearance, location, landmark, and vascularity. Give graph, image, video, volume, and try to scan with a different probe when there is a lesion, because it can give some more information. And your report should be concise, and when the scan is normal, there should be minimum description, and counseling note should be there in case of abnormal report. What we have understand, what we have seen when we do counseling in abnormal case, the patient, when they sit from the consulting room, they are asking just counseling note. They are not worried regarding report. Then we tell them, you have to take this counseling note also and a report also. So for them, they feel like that counseling note is so much important for them. In August, there is a conference in Delhi. Society of Fetal Medicine is organizing that. Dr. Paladini and Dr. Poo is there. Please register for that. Last weekend of September, there is a CUSP conference which happen every 2 years, organized by Mediscan Chennai. And this is a platform every Wednesday, free learning and sharing platform. Anyone can join. Thank you very much.
CME and markers, the next step in prenatal screening takes us from the ultrasound probe to the molecular biology. So today, genetics is no longer future, it is very much the present. So may I welcome Dr. Sarjan Shah sir for the talk, The New Era on Cell-Free DNA. He is the director of Green Array Diagnostics Genomics, Pune.
Good morning, everyone. Very difficult to follow Mayank sir, but I'll try my best. First of all, I'd like to thank Dr. Munjal for inviting me for this conference. And of course, before I start, I'd like to acknowledge Prashant sir. So 18 years back when I started my journey in pathology, though, he called me up one day and he said, Sarjan, આપણે કંઈક તો fetal cell નું કરીએ. And we started this test called Clear Betke test, and we did about 100 patients or so. So 18 years back, he started this clinical research journey, which probably now still I'm continuing. I'm still on cell-free fetal DNA. So thank you, sir, for that. So yes, cfDNA, the new era in NIPT. We have briefly seen in previous slides about prenatal testing. First trimester testing, we all are aware about the double marker, the NT scan. The second trimester screening, the triple marker, the quadruple marker. Of course, the triple marker is now outdated and everybody prefers quadruple marker. There are screening tests, the marker study, the nuchal translucency and NIPT. And as Mayank sir also pointed out, that diagnostic test remains two, that is CVS and amniocentesis. So whatever findings we see in the screening test, we need to confirm by invasive test. It all started back in 1960 when maternal age was the first marker that was seen as a marker to see for prenatal defects. 1980 is the first marker AFP arrived, 88 triple screen, 96 quadruple marker. 97 was first combined study was done, and NIPT was introduced in 2011. And now the new kid on the block is NIPT SNP. Of course, any test needs to have a sensitivity. So the early marker, the double marker, has the sensitivity or detection rate of about 65%. The combined first trimester screening ranges from 90 to 95%. And the best is when we add maternal age, the nuchal translucency, and the sonography finding with double marker. And second trimester screening varies from 70 to 75%. Coming to brief history of cfDNA, actually the placental cells were found first in maternal lungs in eclampsia patients in 1890. In 1947, the cell-free DNA was isolated. Now this was isolated from cancer cells. In 1990, the intact fetal cells were found in maternal blood, and that gives the basis for the Clear Betke test also. Cell-free fetal DNA was found by Lowe. Lowe is one of the gentlemen who has worked tremendously on cfDNA, and in 1997 he found fetal DNA in maternal cell, and in 2010 he could actually sequence the whole genome of fetal DNA. He could analyze all the genetic defects. He could do exome, he could do whole genome sequencing. Now we have developed the capability to find few DNA markers and do the whole genome sequencing also. So what is this cell-free DNA? Cell-free DNA is the DNA existing as a short fragment circulating in plasma and other body fluids. So we all remember our MBBS studies that there is a cell, there is a nuclei, and there is a DNA. Now there are certain processes like apoptosis and necrosis which gives rise to fragments of DNA. And this fragment of DNA we are trying to capture as a genetic laboratory from maternal blood. So cfDNA has a few applications. Like in oncology, we all now know something called ctDNA. ctDNA is nothing but when we have given a treatment to a cancer, a chemotherapy or radiation, and there are DNA fragments of that particular cancer cells is again moving into the bloodstream, and that we analyze. That cfDNA is used in oncology. In transplant patients now, after transplant, we are analyzing donors' DNA, which is remaining in the circulating blood. And of course, the cell-free fetal DNA that is used in prenatal screening. Now, what is NIPT? It's an advanced genomic screening ecosystem that analyzes this fragment of fetal DNA circulating in a pregnant lady's blood to evaluate specific fetal chromosomal variations. We usually take sample after 9 weeks. About 10 cc of sample is taken in a specific tube. Now, what are the different platforms one can use for this cell-free DNA? Of course, the conventional, all are aware about the NIPT, that is the whole genome counting. It's called low-pass whole genome sequencing. So we are actually analyzing the whole genome and sequencing it in conventional NIPT. Now there is new kid on the block is the SNP based, which has actually given far more better sensitivity for micro deletions and single gene defects. And there are targeted and hybrid approach where we target a particular chromosome and do the NIPT. What matters is the performance metrics. So yes, it is best suited for trisomy 21 with sensitivity of 99.7% and specificity of 99.96%, giving a false positive rate of 0.04%. Trisomy 18 and 13 varies from 98 to 99%. It reduces a little to 96% for Turner syndrome. And now the American College of Medical Genetics has allowed testing for one microdeletion, that is DiGeorge syndrome, that is 22q11.2 deletion, but the sensitivity is only 75%. Now, what is this cell-free DNA and what is the fetal fraction? So when a 10 cc blood is taken, out of which 10% is this cell-free DNA and the fetal fraction. So fetal fraction is the percentage of total maternal plasma cfDNA that is of fetoplacental origin. So it varies from 10 to 12%. Rest of the sample contains maternal blood. So what is the average fetal fraction? So fetal fractions till 18 to 20 week, it stays around 10 to 12%. But it gradually increases and till term we can actually find this fetal fraction. But after delivery, it vanishes within 2 hours. So actually till term we can do NIPT, but of course we need to diagnose this much earlier. Now what are the technologies? Now we have got the blood sample, we have cell-free fetal DNA in it, and now we need to separate it from the maternal DNA. So of course first is, of course this is used in European countries, is the chromosome Y markers, where all the male patients' markers they study because sex determination is possible in these countries. There is comparison of fragment length of maternal DNA and fetal DNA. So fetal DNA and maternal DNA, when we put this sequencing into a computer and we run a program, it shows different peaks. So maternal peak will be at certain length and fetal will be at certain length. And on those basis, we identify what is fetal DNA, what is maternal DNA. The other methods are detecting specific STR markers or detection of SNPs. And we can also detect methylation. Now what is methylation is correction in a DNA sequence. So majority it happens in maternal and not in fetal. And unmethylated whatever DNA remains, that is your fetal DNA. Now what are the causes of low fetal fraction? It could be technical also and biological also. It could be fetoplacental also, and maternal factors are also involved. Fetoplacental factors, the biggest factor is the mosaicism, which I'll be discussing in subsequent slides. And sometimes fetal aneuploidy itself gives rise to low fetal fraction. And the maternal factors are of course we all know the maternal body mass index is one of the biggest factor for low fetal fraction. Maternal medications, when we are giving blood thinners to a mother, that gives rise to low fetal fraction. And autoimmune conditions like SLE, which also has been found to correlate with low fetal fraction. Now the most well recognized and clinically the significant influence on fetal fraction is maternal weight. A study found out that fetal fraction decreases to less than 4%. Now 4% is the barrier that is minimum required for a good NIPT test. Few laboratories have validated to 2 to 4 also. So till 2% it has been validated, but each laboratory will have their own validation of fetal fraction. So my laboratory has 3% fetal fraction, which we have validated. So when the body weight is 100 kg, there is a reduction of 7%, 110 kg showed 11%, and 160 kg women showed 50% reduction in fetal fraction. Now we wonder why this happens. So maternal weight increases the maternal part of cfDNA, which was supposed to be 90%, that increases to 95-96%. Probably because of the maternal adipocyte inflammation and necrosis, and not necessary that the placento-fetal origin fetal DNA has reduced, but the maternal part has gone up. Now, when NIPT test is not reliable, when there is a confined placental mosaicism, when we are analyzing trophoblastic cells of placenta from maternal blood. That's the only connection between fetus and mother, right? So it is the trophoblastic cells. So when the anomaly lies in placenta or anomaly lies in fetus, then it can give rise to discordant results. And in trisomy 21 it is 2%, but when we go to trisomy 13, it is 22%. Of course, in vanishing twins, it will show a false positive result because the remnant of that vanished twin, the cfDNA, will be circulating again in maternal blood. Maternal own chromosomal abnormality will give rise to a false result. There is maternal malignancy. The malignancy itself will have its own aneuploidies, which will give again rise to a false positive result. Uniparental disomy, that is, a fetus has harbored both the chromosomes from a single parent. So now uniparental, it has come from 2 chromosomes, and mother it has come 1. So it will give rise to false positive result. Now what NIPT cannot give us, right? So it is the neural tube defects, structural anomalies, most single gene disorders. We saw that only DiGeorge is the one which is allowed in practice to give a report to, and polyploidies, which NIPT cannot detect. So this is the one I was talking to you about, that there is a chromosomal mosaicism. There is a diploid cell which is normal. Diploid means there are 2 chromosomes. Trisomy is there is an extra chromosome. So now let's say we have taken blood and now the anomaly is confined to placenta. Placenta is also developing with the fetus. And if the anomaly is confined to placenta, it will give rise to false positive result. And we have taken sample, it has come from placenta, and the anomaly is confined to fetus, then it will show a false negative report. Now, what is the incidence out of 1 lakh live birth? So, of course, we all know that Down syndrome is the one which shows about 121 cases in 1 lakh cases, the highest of all. The interesting story starts afterwards, that we can see DiGeorge and cystic fibrosis making an appearance before trisomy 18 and 13. That is why the NIPT SNPs has come into picture, that the thing needs to change. We need to identify these diseases somehow. Of course, the confirmation will be needed. Mayank sir also said that these are all screening tests, but to come to know about it is most important. Microdeletions are more common than Down syndrome in younger women. So I'll come to the positive predictive value of each test, and we'll see that what is the PPV of NIPT. But in this case, younger women are far less to develop Down syndrome than when you have passed the age of 35 years. So now what is the difference between a sensitivity and positivity? I've just told you that NIPT is 99.99% sensitive. That means it has the ability to find a positive. Now whether it is true positive or not, that is the positive predictive value. So where does it lie there? So in an NIPT, it is 80% positive predictive value. That means out of those 99.99%, 80% of time it will be correct. And it reduces gradually with trisomy 18 showing about 62, trisomy 13 showing about 35%. Now we'll wonder that with 35%, why should we do this test, right? So when we take into account a double marker or a quadruple marker, the positive predictive value lies 2 to 5%. So instead of relying on 2 to 5%, we need to upgrade ourselves and go to at least 80% for Down syndrome. Now, what I was talking to you about the maternal age part, we all know that aneuploidies increases as the maternal age progresses. So when an age 20 mother comes to us, the positive predictive value of an NIPT is 27%. But the same person at 40 years will give us a positive predictive value of 93%. We all are aware that the risk is 1 in 2000 to 1 in 84, and it crosses 45, it is 1 in 8. So every 8 women, 1 woman will develop a Down syndrome. Now, of course, what are the applications for multiple gestations? So, surprisingly, the fetal fraction lowers in twins. No-call rate is higher. It cannot attribute aneuploidy to a specific twin in a DADC twins, chorionic diamniotic baby. We cannot define that which baby will have this defect because the DNA is the same. Actually, but no serum screening is valid in twin pregnancies, and sex chromosomal anomalies are not screened or not recommended in twin pregnancies. So, when we come to the sensitivity part of it, in a twin pregnancy for NIPT, it is 95% for trisomy 21. When NT and serum screening is combined, it is 87%, and serum alone is 60%. Now, the biggest challenge comes in vanishing twins. That, as I told you, that vanishing twin will have far more cfDNA, which is remaining after there is a vanished twin. So, what to do? So, ideal scenario is after you identify the vanishing twin, wait for 8 weeks. 8 weeks is a minimum period required. It can be 12 weeks also, but at least we need to wait for 8 weeks before we send an NIPT sample. Now, coming to Society of Maternal and Fetal Medicine, what are their recommendations for NIPT? Of course, they recommend doing NIPT for trisomy 21, 18, 13. Sex chromosomal aneuploidy are also recommended, but SMFM is not recommending microdeletion syndromes. For twin gestation, they are recommending a first-line test NIPT. Now, in SMFM, every time it releases a study in JOGI, the Journal of American Obs and Gynae Society, that gives us an idea that how these risk groups are divided. And they've divided the risk group for doing NIPT or risk calculation into two, that is traditional risk factors, high risk, low risk. But in the latest 74 edition, they have identified it into high risk group, intermediate risk group, and low risk group. So what is a high risk group? High risk group is more than 1 into 50 risk. If it has been observed, then do not do NIPT. Go directly for invasive, because there are far better chances that you will get things positive. From 1 in 50 to 1 in 1000, we need to do an NIPT. And after if the risk is more than 1 in 1000, then need not do anything. Reassure the patient and do the scan again. By doing this, they have observed 40% reduction in invasive testing and increase in detection of Down syndrome from 94% to 98%. Now, this was a Danish study that they had produced which showed that 1 in 50, 1 in 50 to 1 in 1000. The Professor Nicholas or the FMF suggests that this needs to be 1 in 100, then 1 in 100 to 1 in 1000, then another study which suggests 1 in 250, 250 to 1000. So there are different studies and different markers are there. So I feel that 1 in 50 to 1 in 100 is the ideal way to go about. So this will obviously help in marked reduction in the chorionic villus sampling. As Mayank sir said that, why we need to prefer amniocentesis than CVS. Because CVS again will give you a placental picture, and amnio will be the one which will have more of a fetal DNA in it. So one needs to prefer amniocentesis over CVS. American College of Obs and Gynae Society also recommends trisomy 21, 18 and 13 screening by NIPT. American College of Medical Genetics has also come up with their recommendation that it should be done for trisomy 21, 18, 13 sex chromosome analysis. For twins, they have recommended only for trisomy 21, 18 and 13. They are conditionally recommending doing it for 22q deletions. And for other chromosomal number variations and other rare autosomal trisomies, they are not recommending it. Now, this was about NIPT. We are talking about CFDN and what are the new frontiers which are coming up. So, NIPD. Now, we are moving from NIPS or NIPT to NIPD. We want to diagnose things. So, this is where the single gene analysis comes into picture. We can diagnose diseases like Duchenne muscular dystrophy, spinal muscular atrophy. And these are SNP based. So, what are these SNPs? We have studied ATCG pattern in DNA. Now, when there is a change in this ATCG pattern, a change is called an SNP polymorphism. And this single change we are trying to identify. This single gene disorders we are trying to identify. I had a very good discussion with Prashant sir about the RHD genotyping, that we can now perform with the same NIPT sample, we can analyze that if the baby's blood group is positive or not. Now, at Green Array, we are working on a pre-eclampsia prediction model and a GDM prediction model. So these are polygenic risk scores. So what happens is we take the NIPT samples, we are identifying certain markers for the mother that if we can predict in the same NIPT sample that this lady has more chances of high BP or high blood sugar. Then cfDNA methylation analysis can be done. Methylation analysis is what DNA repair is all about. We can actually identify with the methylation analysis exactly the fetal DNA concentration. Expanded cell-free RNA can be also done. There is a study called transcriptome study. Now this also we are doing in our research cell that will predict the preterm birth and IUGR. So NIPT take-home messages, it of course helps us in early detection, highest accuracy for trisomy 21, 18 and 13, zero fetal risk, and it also screens for sex chromosome analysis. But it is a screening tool. We don't know whether the sample has come from placenta or the baby. Of course, 99% of the time it will be from the fetus, but we are not too sure about it. So confirmation is always required. Thank you.
Thank you, sir, for your insightful talk. May I welcome Dr. Munjal, sir, to felicitate, sir. From the first trimester structural screening to detailed fetal anatomy assessment and finally the genomic era of prenatal screening. We would now progress towards our panel discussion. And so panel discussions are sometimes more exciting than lectures because this is where experience, evidence and healthy disagreement come together. So for today's panel discussion addresses a question that is both clinically important and intellectually stimulating. Can we reliably detect major congenital anomalies before viability? To lead this discussion, we are privileged to have Dr. Janak Desai sir as our expert. So Janak Desai sir is a senior fetal medicine consultant for over last 27 years. He's a chief faculty for fellowship program of fetal medicine at SVP Hospital, Gujarat University. He's also a chief faculty for fellowship program of fetal medicine at Bhai Kaka University, Karamsad. He's the president of Society of Fetal Medicine Gujarat chapter, Foxy and ICOG recognized teacher for fetal medicine. And he has trained more than 100 gynecologists in the field of fetal medicine. So may I welcome all the respected panelists. Just a sec. So to join, I request all the esteemed panel comprising leaders and experts who have collective experience to come on the stage. Just a sec. And the modern Dr. Ripple Gevaria madam to come on the stage. So our panelists, Dr. Ami Mehta madam, Dr. Devanshi Shah, Dr. Kanan Kotadawala, Dr. Viral Pandya sir, Dr. Riddhi Mehta madam, Dr. Riddhi Bhatt ma'am, Dr. Forum Acharya ma'am, Dr. Devang Patel sir and Dr. Bhumika Shah madam. Please come on the stage.
Age of viability. We know now there is a shifting of a number of ultrasonographies during antenatal period, and it has changed the entire picture of diagnosis and management of the pregnancies. So we'll start without wasting time. I think it's Sunday morning and everybody wants to go back home early. So I would like to invite Dr. Janak Desai sir. Thank you so much for being an expert of our session. And without wasting time, let's start with the discussion, the age of viability. Would like to hear from you, what do you mean by age of viability from your perspective of legally and as a fetal medicine aspect and as an obstetric aspect? Dr. Devang, Dr. Viral, I have not particularly written anybody's name. Anybody want to answer, they can.
So I am not a I'm not a practicing obstetrician, but for me, what I would say is that the age at which my neonatologist is comfortable at managing the baby and giving a good outcome is the age of viability. That is what is the practical interpretation.
Okay, thank you. So there is difference between age of viability and as per our PCPNDT Act, age of allowing the termination. So along with the age of the viability, I think we should focus more on the age of termination of the pregnancy, which is around 24 weeks of the pregnancy at present, correct? So Viralbhai, what is your idea that all the anomalies should preferably be diagnosed before the age of termination of the pregnancy?
That's not practically or scientifically possible because not all the organ systems get developed by the age of termination limit. So it's a very idealistic thought if we say that we can diagnose everything by then.
Correct. So message is very strict clear that we want to diagnose anomalies before the age of allowed termination of pregnancy, but still our hands are restricted. So let us see whether we can try our best to identify the anomalies before the age of termination of the pregnancy. Yes. Right? Yeah.
So if you cannot diagnose before age of like 24 weeks legally it is, then there is a provision, then the medical board is there is a high court is there is a facility available.
Yes.
So there are venues you can, when there is not possible, then there is.
Yes, that's a very good information that even major lethal abnormalities identified after the age of termination of pregnancy, say after 24 weeks, we have some another options. So at least to have the couple and the treating physician. Thank you.
Would like to hear from you, what will be the roadmap, or do we have a toolkits we can maximize the detection of major congenital anomalies before the 24-week of pregnancy? Anybody wants to?
So, as mentioned by Dr. Mayank sir in the previous lecture, following a good protocol, we would be able to cover most of things that can be diagnosed at a particular gestational age, and keep modifying the protocol, keep updating yourselves, keep reading the evidence-based researches.
So if the pregnancy is low risk, then we follow the normal NT scan at 11 to 13 week and an anomaly scan at 19 to 22 week. And if there is a high risk or suspicion, then if there is suspicion at NT scan level, then we ask for early anomaly scan around 17 week. And if we have some doubt at anomaly scan, so we can ask for fetal echo or fetal neurosonogram depending on the suspicion.
Yes. So we have a, yes, okay. You can.
And as a maternal and fetal medicine specialist with special interest in obstetrics, we should be very much considering CVS and amniocentesis. So CVS at around 11-12 weeks and amniocentesis at 16 weeks. So it will help us for the termination of pregnancy smoothly.
Yes.
Okay, so it's very important to have a protocol-based sonography or protocol-based scan. So means we at least have to offer at least 11 to 14 week scan and 18 to 22 or 20, maximum by 24 weeks of the pregnancy. So very good message is that, as Mayank Bhai said and Dr. Rajat has said, that always a protocol-based sonography 11 to 14 weeks or 18 to 22 weeks. Reassure the couple or reassure the physician that even before that, just don't try to jump the identify anomaly. Especially those are some couple, having previous, say any anomaly, CVS or CNS or any anomaly, they want to pop up you that please, I will come at 6 weeks, I will come at 8 weeks. But reassure them that this is the time and this is the protocol.
So without wasting time, let's see some cases practically. 19-year primate twin conceptions came for the first trimester scan, and these were the scan findings. Can anybody, once you look around and please give us a feedback what you are suspecting.
So this shows the, as well as in the abdominal wall, we can see the loss of integrity with the protruding bowel and the liver without the covering sac. So most likely this could be gastroschisis. And is there anything else? Anyone
We
else
would
has?
like to need another opinion also, if anybody else have any other findings other than this.
I'm honestly not very happy with the spine if you have the...
Yes, there is a spinal defect, yes.
Why do I feel that the bowel is outside the amniotic cavity?
Yes, perfect. It's the entire abdominal contents are outside of the amniotic cavity. If you can see the 3D volume, there is an amniotic membrane. We are tracing and we are going through, and your limbs are seen in the last right lower image. The limbs are inside the amniotic membrane. As soon as you go now, right now, the liver, intestine, everything is outside of amniotic cavity. It's a limb body wall complex abnormality, or you can say amniotic membrane rupture sequences. How you will counsel and prognosis about the current thing?
So limb body wall complex is something that we need. It requires discontinuation of the pregnancy, and as you said, it is twin, so I suspect the other twin will be a normal one.
Other fetus was normal, absolutely.
Yes, so I mean this is the right gestation to go for a selective reduction of the fetus which is abnormal and continue the other pregnancy in a case of dichorionic twin.
Also, we would like to explain that it is mostly a developmental anomaly, not associated with genetic or chromosomal defects, so that would ease out the counseling process. And we need to keep a follow-up on the other apparently normal twin as well.
So you can offer selective reduction. This second baby which is abnormal going to die, it is a lethal anomaly. So when you offer selective reduction, then there is a risk of at least 3 to 5% abortion risk. So I am not 100% sure. I will not like to do selective reduction in this type of lethal anomaly. Suppose it is anencephaly and there is chance of polyamnios, then there is a counseling part comes, okay, there will be a risk of preterm labor. So there will be a so-called advantage if there is a less than 32 weeks pregnancy termination because of polyamnios, then you can offer on those basis. But the lethal anomaly, twins, I am very reluctant to offer this selective reduction.
The same thing was discussed with the patients with a risk of reducing the fetus, because that fetus was presenting fetus and a twin conception, and the cervix was 27 mm. And other than that, continuation of the pregnancy, patient was from periphery, patient denied further reduction or any other further management, and by her bad luck, she terminated at 21-22 of pregnancy, the entire pregnancy. So we'd like to hear from all of you which anomalies in a first trimester you can diagnose very confidently, straightforward, with a good reduction rate of almost more than 90%.
Yeah, please.
From CNS to anencephaly, then open spina bifida is now being diagnosed with the help of other the BS to BSOB ratio, the crash sign, then apparent ventriculomegaly, gastroschisis, megacystis, and holoprosencephaly.
Some significant cardiac chamber disproportion anomalies, hypoplastic heart syndromes, some abnormalities related to the limb, significant limb reduction defects, defects like the amnion rupture sequence that we just saw. Of course, then anterior abdominal wall defects are also something that you can see if you do a good transvaginal scan.
Yes, so there is a list of things which we can easily diagnose in a first trimester screening, almost with an accuracy of more than 90%. So these are the list which, rather than directly getting this type of anomalies at 20 week of anomalies scan, we get in a first trimester, and early intervention of the lethal anomalies we can do. We'll move on to the second case, a 36-year female, second gravida, previous one LSCS, right now IVF conceptions at 12 week 2 days. She came for a first trimester screening. Her nuchal translucency, CRL, DV flow was good, nasal bone was present. We did a further anatomical assessment, and this was the cardiac findings we got on scan. Oh, sorry.
This is a axial section of the heart, of the thorax, where only single side, there should be two filling of the ventricle side by side, but only single ventricle is being filled. And in the last image, last video, it was showing that the vessel filled was also a single. So there is a probability of left hypoplastic heart syndrome.
Yes, it was a left hypoplastic heart syndrome. As we have already discussed about the prognosis and counseling, this type of anomalies, we can straightforward give them an option of termination of pregnancy after thorough counseling with the, if needed, by pediatric cardiologist also. Though this can be, this type of severe cardiac anomalies we can diagnose even in at the 12 or 13 week of pregnancy. We'll move to a case 3. 26-year primey, they came for a first trimester screening at 13 week 2 days, no any significant past history. This was the section of her nuchal translucency, nasal bone, DV.
Sir wants to add something.
Yes, sir.
Sorry, it will take time, but the previous case, when you terminate the pregnancy in the first trimester, the obstetricians sometimes very reluctant to for the genetic test. So my suggestions to all obstetricians that even after termination of pregnancy, you can do genetic test up to the whole exome sequence. So that for the next pregnancy, it will be guide. So in this type of left hypoplastic heart syndrome, that can be a genetic abnormality and that can be a recurrence rate. Thank you.
Yes, so it's a very good message that in any kind of the major anomaly, when we are going for the termination, yes, that's a final verdict. But before the termination, before termination, we can go for invasive, say for the immediate CVS, or at least cost effectiveness is after the termination, we can go for the DNA analysis. After the termination, we have to do the genetic analysis.
If patient is refusing, not ready to spend them, at least DNA preservation, at least DNA preservation. That will be without cost. Most of the genetic lab or minimum cost 1,000, 1,200, 1,500. The genetician, how much you cost? Give the minimum DNA preservation only.
2,000.
Okay, so it is,
Yes, so
patient is
maximum is
not paying,
2,000 is the limit.
obstetrician
Right,
can
yes,
add
yes.
the cost in their delivery or termination. Thank you.
Yes, so that's a very good message for today's talk, that at least we have to have DNA preservation of any terminated pregnancy for major anomaly. Because the couple is very, very anxious at that time of the procedure, and even the consulting doctor may not be ready, or they may not be ready to spend the money. But when the next chance, after 1 month or 2 months, they will come with the same thing, that give me the Folvite and the Folinine tablet and tell me the chance about same abnormality in the next pregnancy. Then you are in a doubt. So always please offer at least DNA sampling. Okay.
If I can take 30 more seconds, not going into the details, but the technical limitation of karyotype means that from a POC, you have a more probability of karyotype failure. So rather than karyotype, a microarray is a more suitable test, or we have specific tailored POC testing tests available rather with a lot of labs now, which are not based on dividing cells. So please try to avoid karyotype if you are doing a POC testing, at least.
Yes. Thank you.
So this is the another case where patient came for a first trimester scan, and these are the findings. Nuchal translucency, CRL, ductus venosus flow, nasal bone was there, and we were doing an anatomical assessment again. కేవలం క్లిక్ బటన్ వస్తుంది. लास्ट वाली 2D image आ रही है clip. 2D was not good. It was a very high BMI and poor penetration of ultrasound. So this is the color from where you.
Kind of it is.
So this is a repeat scan was done, and this is the 2D image of that.
Let's look for the insertion of the valves. Right? AVSD. So it's an AVSD.
It's an AVSD. Patient was even first trimester counsel with high anti and suspected cardiac disease for they need to do a genetic testing. Patient again came at 17 week after taking 2 or 3 opinions, and finally invasive testing was done, and that turned out to be a trisomy 21. So always not only about the nuchal translucence in nasal bone or ductus venosus, many a time we found some structural abnormalities also where we can found trisomy 21.
So increase NT and AVSD nearly 100% 21 in first trimester. If you diagnose AVSD balanced or unbalanced with increased NT or absent nasal bone, nearly 100% 20, nearly 100%.
Yes, that's so right. That increase NT with major cardiac defect, especially the AVSD, is a Down syndrome. But whenever you are having a borderline increase NT, when you are having a borderline increase NT, along with suspicious of cardiac abnormality, as in this case, we can wait till early anomaly scan, right? So we can wait for 16 or 17 or maximum by 18 weeks, we can try to do the early anomaly scan and try to pick up the anomaly and help the couple.
Many a time the patient came at 17 weeks with NIPT low risk and the same cardiac finding. So at that time it's very difficult to counsel them. So whenever you are finding some structural abnormalities, there is no meaning of doing NIPT in that case.
Yes.
So that is a very important thing. And then when we ask patients to do a genetic testing, madam, બધા જ chromosomes નું analysis થઈ ગયું છે, because lab people, they always give all chromosomes normal in NIPT report. So that is the practical problems we are facing when we counsel this patient.
Sorry, but the genetic lab will give you what you ask for. So I suggest that for NIPT, please ask for only 3 things, 13, 18, 21 chromosomes, not more than that. That will cost more to the patient, little information advantage.
The only thing I want to also add on to, sorry, yes. The only thing, the way you convey message to patient is sometimes difficult for us to counsel. It is, yes, genetic analysis done, but it is only for trisomy 21, not for other genetic abnormalities. So that is important thing, and many times patient have a misconception of genetic testing of the baby is absolutely normal. Patient opted for the termination of pregnancy. Another case, a primey, 34-year female, spontaneous conceptions. She came for a first trimester screening. Her anti-scan, CRL nuchal was good. DV flow was okay. Nasal bone was present. IT is obliterated, sir. It's in brainstem and brainstem occipital distance, which was 1.7.
In that case, we have
The rest anatomical evaluation was absolutely normal, as because the IT was not able to see. We start screening the spine, and we found very subtle defect in the lumbar region, and it was not a closed neural tube defect. It was an open neural tube defect without any myelomeningocele. And even when we were doing a brain examination, there was a dry brain, and there is a complete shifting of brainstem.
So
Crash sign is there.
So what is the opinion from the panelists that should this anomaly be identified at 11 to 14 weeks, and with how much sensitivity of surety?
Every time whenever...
Please, Mike, please.
So for such cases, the best clue comes from IT. So if
Correct.
we are taking a good section of NT, then this will not be missed, because all the open defects, they usually have an obliterated. It is not always there, but in most 98% of cases, we'll have an obliterated IT, and this could not be missed if an NT scan is, the NT section is properly seen.
Correct. See, increase IT was abnormal, but spine seems to be normal even with transvaginal examination.
With
even with the
subtle defect here.
Yeah. So what should we do? Suppose only in suspected increased IT. Rest everything comes up to be the normal at our 13-week scan. So what should we
Early
do?
follow-up. Early follow-up.
Early follow-up.
Yes.
Is there any role of any screening test? Blood serum screening test? Can we go for the alpha fetoprotein, say for quadruple marker?
Quadruple marker also has to be done between 15 to 16 weeks, and by that time, by scan also we can know very easily. So either like an alpha fetoprotein is not having that much sensitivity as we do it on the scan.
Okay.
So rather than alpha fetoprotein, I think direct visualization of the spine
Is
would be a
better
option.
Okay.
according to my-
So direct test is better than the indirect. But should we combine? Otherwise, at least go for that test. Because you know always the couple come with lots of paper with you. That
So in high
I'm 17 weeks
resource-
and now you have to do this test.
So in high resource settings and where the patient is fine with spending on both, yes, we
Okay.
should. And if it is on and we are very confident on the scan itself, then it's not required.
So ultimately, it might be the patient's choice.
Yes.
That yes, there is abnormality, we have detected, it is seen. If you want to go for some other test, you can opt for. Anything you would like to?
So the confirmation of this is a anomaly in which the life of the fetus depends. Means either termination or not termination. So direct evidence at 16, 17 weeks to confirm is what I prefer. If you are in doubt, please, there is no hurry to terminate the pregnancy. Question remains alpha fetoprotein. Now alpha feto will be corroborated, it's not a definitive evidence. So given a choice, in India, I will not advise alpha fetoprotein.
Yes.
Once there is a obliterated IT. So there is a corroboration. That is not a definitive reason. Only thing which is importance of alpha fetoprotein in USA or some advanced country, they routinely do it. Why? It is as a screening test. So IT to detect is not most of the here sitting here will not be able to do. So alpha fetoprotein is their role for obstetricians is very good test.
Yes. So please.
So just
please
wanted to add, we had one patient from US and they had done the AFP and they were counseled there that this is for the spine and neural tube and it is normal. And at 20 weeks, I diagnosed that there is a neural tube defect. It was very difficult to counsel her that. So I think the scan should be gold standard in this.
Yeah, please.
So what I would like to add is all the markers that we have talked about, they are at the end of the day markers. They are not direct evidence, whether it is the crash sign, whether it is the IT. The direct evidence is just the spine. And seeing the spine is the gold standard, no matter what other findings you have, because these markers may not be that very evident in cases where it's a covered defect, or even in some defects, they don't show up this early. So you don't necessarily pick them up that well in the first trimester if you do it especially a little early, because spine also you won't be able to see that well if you are doing an NT scan, let's say at 11 plus 4 or 12 weeks. So it's very dependent on the position of the baby initially, and the indirect markers are indirect markers. So whenever it, as sir said, it is a decision making diagnosis, you need to have a direct evidence and you cannot rely on the indirect findings or the markers. They are screening tests at the end of the day. They can be a false reassuring, as we just heard. So a direct evidence is the gold standard.
Yes, thank you so much. Anybody want to add?
And one more thing that like ideal time is 11 to 13, that 11 to 13 plus 6 that we read in the book, but ideally it should be done around CRL is more than 60, so that we cannot miss the minute detail, because some of the cardiac and spine defects are evident when the CRL is more than 65. So usually we ask this NT scan around 12 plus 4 weeks.
Yes, so this is a very good point, that although the Fetal Medicine Foundation has given us the limit that from 45 to 84 of the CRL, you can do the NT scan. But it is always better to do NT scan at 60 plus, at least 55 plus. Minimum 55 plus CRL. If patient came, please let them counsel at that better to come after at least a week, so that we can pick up abnormalities at earliest time, and it can give us good confidence.
And just in related to spinal dystrophism cases, we know that they are related to folic acid deficiency, but recent evidences show that there is also a relation with 22q11 deletion. So we need to offer genetic testing in these cases, because most of us think they could be because of folate deficiency, which is quite common in our country, but we need to offer genetic testing in such cases as well.
So the 10% of open neurotube defect have a, it is a multi-factor, everybody knows. It is not only folic acid, it B12. In India, it is beyond doubt proved, not only folic, it is a B12 also. So when you replace, next pregnancy, not only folvite, it is a folispore. Folvite plus B12, number one. Now question arises when first time, what I do, I am very conservative person. So when patient comes to first time with the open neurotube defect, I counsel them that it is a multifactorial. The amount of, if you are due to the folic acid B12 deficiency, the pre-conceptional replacement will cure it. But there are 10 to 12, 15% it is multifactorial. Multifactorial includes genetics. So 2 consecutive open neurotube, then I will advise invasive, otherwise not.
Okay, thank you.
That is my way of practice.
Okay, now one more question. Similar to this, suppose abnormal IT. Nowadays we are getting lot of reports between 11 to 14 weeks that suspicious of club fit, unilateral or bi-club fit. What is your opinion, dear panelists? Please.
Club foot in first trimester should not be diagnosed with surety, because most of them are they turn out to be false positive. So we should wait. It is most of the time positional. So we should wait. Rather than scaring the patient, we should just follow up and diagnose that at a later gestation.
So just don't press the panic button.
Yes,
right?
that's my.
Anything anybody wants to add, please?
So isolated club foot, you can wait, because you are not, there is no hurry. There is, you are not going to terminate the, you are not yourself going to advise in counseling in favor of termination pregnancy. But if there is something else, then at that point of time you can give the possible, and then you can 16, 17 confirm and go for the.
So is it okay that I have not identified the club foot at 12 weeks and it turned out to be the club foot at anomaly scan? Is it possible?
Yes. Always possible, even scientifically, not only. Any abnormality missing by anybody is possible. મારું મગજ જે વખતે શું ચાલતું હશે મને ખબર નથી. So don't blame each other anytime. કોઈ એમ કહેતું હોય કે મેં કોઈ એનોમલી મિસ કરી નથી, either is a liar or non-practicing person.
So the biggest lie of the day, that I am the person who has never missed an anomaly. Right. Okay, anybody wants to add?
Yes, so if we had done NT scan and if we have not mentioned club foot, and at 20 week we can see, then technically and according to guideline it is okay, that because we are just supposed to see 3 parts of the limb and its alignment, not we are supposed to diagnose club foot at 13 weeks.
Correct. Okay, thank you.
So this is, we need a list where we may or may not diagnose the structure anomalies even in 11 to 13 or 14 week of pregnancy. Like the last case, what we have shown, the neural tube defect, it was open, but still there was no clear-cut evidence of myelomeniingocele or anything. So there are a list of things. Cleft lip palate, again, it might missed in a first trimester screening. It depends on many factors. Left hypoplastic heart syndrome, extremities, not complete absence, but yes, some extremities abnormality might be missed in the first trimester. So, yes, yes. Any from your side, if you want to convey anything on the list of
we
things.
just want to know that how comfortably we can diagnose major abnormalities of different systems at 11 to 14 week scan.
You have listed AVSD. Complete ASD, I now believe most of us can diagnose in first trimester. Partial AVSD, I don't think so.
Correct.
So AVSD, so there are 3 groups of abnormality in the first trimester or any anomaly. So should be diagnosed, may be possible or not possible. So 3 groups. So AVSD comes, AVSD, most probably you will be able to diagnose complete AVSD in the first trimester, not partial AVSD.
Yes.
Yeah.
So,
Anybody just give the idea about the anomalies which can be identified with so surety or almost 100% we can diagnose. Then there are few anomalies may or may not be diagnosed, and then there are few anomalies just don't diagnose.
Not able to.
so this is the one of the paper which was published in ESOG by Kipros and group, and they have given a list of the things like that we have already discussed in the after first or 2 case, acrenia, alobar haloprison There's a list of things which we can diagnose at most a surety of more than 98%. And there are certain things like we have discussed open spina bifida or lower unilateral luto, absence of extremities, maybe a many a time fat sequence that can be maybe or may not be diagnosed in the first trimester of a scan. Again, this is one of the systemic review and meta-analysis which was published in 2024, and they have listed us 16 anomalies where the detection rate is as good as 67%, and they have divided the all the categories in a high detection, moderate detection and lower detection. Out of this, the high detection, which is the same what we have discussed and which can be, we detect almost a accuracy of more than 95%. This is the same systemic review. They have given us a list that can be with a sensitivity we can diagnose in a first trimester scans. So why, want to ask you, why we are too much hurry in diagnosing the structural abnormalities in a first trimester scan?
Please. So what is the importance of early diagnosis of major anomaly?
Answer should be given by obstetricians. RVV or which you you are pressuring us to diagnose early?
That is the only aim or the objective of the obstetrician is we can easily terminate the pregnancy in the first trimester. That's it. That is the only motive.
Any other reasons, any other, from your side, any arguments as a fetal medicine, what are the other advantages if we diagnose early?
Early diagnosis. So once you diagnose and genetic test to be done, it will, full workup will 4 weeks. So early diagnosis for 4 weeks. The argument of obstetricians, I was before 3 years practicing gynecologist also, is the early terminations. But how many obstetricians, including myself practicing, if BPD more than 25 mm directly to DNE? Rarely. It is risky, particularly previous years. Number 1. And if you do without directly DNE in the put misoprostol or anything is, the result will not go. You will be 2 to 3 days. So it is better to do termination 16, 17 weeks, fetal medicine also, obstetrics also. Please do not press us. Thank you. You are not going to do it directly, any. I am capable of doing directly MTP BPD 27.
28 and 28.
આપણે બધા. Ask.
I am curious now, sir. I want to know, is there any difference in a mode of termination if you will terminate the pregnancy at 17 week or at 20 or 21 week of pregnancy? Mode of termination and related to whether the complications or anything?
No. It will always be better if the pregnancy is in the later part of the
20-21 week.
20-21 weeks will be better in comparison to 16 to 17.
Okay.
Yes, absolutely.
Okay, sir.
Anything more?
Patient will have a lot of time to doubt your diagnosis. Second opinion.
Yes.
Usually go definitely second opinion. After that they will decide for the genetic test 4 weeks. Rarely before 16, 18 weeks.
With scar, previous cesarean, there is always that kind of the query or an apprehension in the mind of an obstetrician. Whenever there is a previous scar and if you are compelled to do a second trimester termination, there is always that kind of a worry. And in most of the cases, let me tell you, most of the obstetrician will go for a hysterectomy.
Yes.
And rather than a second trimester termination.
So it is out of discussion there. I do not agree, please. Agreed.
Sorry,
No
I
discussion.
diverted the
No
question
discussion.
because out of my curiosity, I have not done obstetric practice that much.
No problem. I am coming back to your question again. You say why we want to diagnose early. From a fetal medicine perspective, all of us are dealing with young couples anxious to have a healthy child. And in today's day and age of AI and ChatGPT, the second opinion is not necessarily from another doctor. So they need time to process the information. They need time to do their own research, which may or may not be correct. That's a different thing. So I believe if it is something that can be diagnosed and you can give that information to the patient to process as early as you can, their decision maybe at 17 weeks would be a little bit more well informed rather than a rush decision at 18-20 weeks diagnosis. और अभी आपके पास टाइम नहीं है, अभी ये करवाना ही पड़ेगा, वरना रिपोर्ट आने में 4 weeks होंगे, तो you will be very close to the legal age, you have a previous scar, this, that. So that becomes a little bit more, a pressure cooker situation for the couple themselves. So I think from their perspective, it is a little bit more of an advantage if they get that information early.
The purpose of asking that question was many a time we face obstetrician to do amniocentesis at 15 week because in guidelines it is written ESO guideline you can do from 15 week onwards. It is very difficult to do a amniocentesis as 15 week or both. That what is.
I totally agree with her.
I'm seriously, sir.
I totally
and
agree
nowadays
with her.
we see a patients of
Now onwards tell to this, who you are pressing you. The sonographically the LMP, if you say 15 weeks, it may not be 100% 15 weeks. So when you do plus minus 7 days, sonography, only God knows at what point of time woman and sperm has picked up. What maximum sonography can done is plus minus 7 days, first trimester, second time plus minus 2 days. So when you are talking 15 weeks, maybe 14 weeks, and your abortion rate will increase. So this is the answer to you.
and second thing, sir, most of the time now patients are very high BMI. With this much of pouch, we have to take out at least 15 ml of amniotic fluid. Technically also it is difficult and we got a many time calls from the lab, they don't get enough cells, then they will put in a culture. Again it will go for 4 weeks. So it will come at 17 or 18 week. So it is always practical rather than do it 15 or 16 week, just wait for 17 week. Nothing will be in a hurry.
So if we are fetal medicine, at least we are, so we have a consensus that we will not do before 16 weeks.
I personally,
So we are not in competitions.
No, this is some practical questions or problems which I am facing. I have done an obstetric practice, no, but not that much. It's just 3 or 4 years of, and there's a reason to questions regarding the mode of termination, whether you terminate at 17 or 20 week difference or early. That's the reason.
Everybody is in a comfort zone.
So it is better to do at 17 week.
So in a very simple manner, just forget about 15, 16, 17 weeks. What we can say that તમારી LMP થી 4 મહિના પૂરા થાય ત્યારે આવજો. 4 month completion means at least 16 weeks plus 5 days. So that is very simple. provided that early sonography has little bit corresponding, that yes, I have done sonography, it is almost the same. That's what the patient and the doctor knows, that please come at completion of your 4 month.
Yes, it becomes difficult when it's an IVF conception, because in frozen cycles they used to transfer at 25th, 26 days of cycle, and if they will calculate from LMP when they come around 14, 15 pregnancy is there. So that is one practical problem. Yes. But yes, definitely 17 week will be better for us as a fetal medicine. So this was the discussion why we are giving importance to the diagnosis of the first trimester anatomical evaluation, and now 11-14 week scan, it has shifted from only nuchal translucency measurement to a detailed anatomical assessment, including if genetic testing required, then also early intervention will be helpful. Now we'll move on to a bit of second trimesters. This is 28-year female primary spontaneous conception, 23 week 4 days. Rest of the anatomical evaluation normal. I am just straightforwarding running the clips. This was the finding on heart.
Okay, so this shows the axial view of 4-chamber heart as well as the 3-vessel view, and we can see the sweep. In the 4-chamber, we can see the...
There is a slight chamber discrepancy.
Yes, chamber discrepancy. There looks like a little bit of displacement also.
Yes.
And in the 3-vessel view, we can see the aliasing in the branches of the pulmonary artery. It looks like absent pulmonary valve syndrome.
It's in classical absent pulmonary valve syndrome with a small VSD was in outflow tract. And again, it was in a volume. There was a to and fro movements in systole and diastole, a classical absent pulmonary valve syndrome's finding. How will you diagnose? Investigation and counseling of this case. I'm not putting a normal anatomical sections of the same patient. It was just only finding cardiac abnormalities with absent pulmonary valve syndrome. Rest of the all examinations were normal. Previous first trimester screening was not done.
Okay, so how comfortably you can diagnose this kind of cardiac abnormality, absent pulmonary valve syndrome, or
diagnosis
for fetal medicine? But we just want to convey that for cardiac abnormalities at 20 weeks, how comfortable you are to have a diagnosis? This can be done. This can be done for other cardiac abnormalities also. For the lethal one, say hypoplastic left heart or hypoplastic right heart or TGA. So how comfortably we can diagnose?
It can be done comfortably at 20 weeks.
Comfortably at 20 weeks. Okay, so what's your next step? Say for this case,
okay, so
as well as for the...
After doing a detailed fetal echocardiography, whether it is isolated or not, other associated cardiac anomalies, we see the extracardiac anomalies, we do the neurosonogram. Are we seeing any multisystemic involvement or not? Depending on that, we can guide about the prognosis, whether it is cardiac, good prognosis. Second thing, we offer the invasive test, again depending on the additional abnormalities, and we offer, we involve the multiple faculties, especially the pediatric cardiologist, genetic counseling, and then depending on that, we offer the patient whether they want to go ahead or not, and then take the call.
Yes, so complete counseling along with the involvement of other specialty to understand the postnatal prognosis and management will be very crucial point when you diagnose this type of abnormality. There is a list of abnormalities which we can easily diagnose. Yes, sir.
What is the percentage of isolated cardiac anomaly without any structural anomaly at the anomaly scale, 20 to 22 weeks?
2 to 3 per thousand, sir.
Almost 2 to 3 per thousand live births. So, see, we are not discussing, focusing only on cardiac abnormalities. We just want to discuss that out of all the systems, all the major abnormalities can be, what kind of the major abnormalities can be detected comfortably at 20 weeks. Suppose patient has not done any previous, taken any care of 11 to 14 weeks or any, directly come at 20 weeks, the first scan. Then how comfortable are we to diagnose the major abnormality?
So these are the list, yes, sorry. Sir. Nice.
So, at least fetal medicine consultant should be comfortable to diagnose almost all major anomalies, except those who are so-called delayed appearing anomalies.
Yes.
So the preference of referring to me to anomaly scan is 22 weeks. 24 weeks the ideal gestal age which the heart will be assessed. 16-18 weeks you can do the biometry well. So we cannot, as a routinely, obstetrician will not send you do the anomaly scan at 18-20 weeks and come for the cardiac fetal echo. For a fetal medicine consultant routinely practicing is the anomaly scan with assessment of the heart included. If something is abnormal with the heart, then I go for the fetal echo. So 20-22 weeks we should be the comfortably in almost all anomaly which are not a so-called delayed appearing anomaly.
Yes, sir. So major cardiac anomalies we can easily diagnose at 20-22 week of pregnancy, except many a time a small VSD or some evolving valvulus stenotic lesions might be appear in the later third trimester we might miss during anomaly scan.
VSD is always there. Sensitivity of diagnosis is less. Only in tertiary care center, please remember VSD diagnosis sensitivity is 30% only. So हमने बद्दान माफ कर जो कोकदाड़ो VSD मिस करिए. So it is VSD is not a delayed appearing anomaly. Always there, yes or no. It may heal, but it is not delayed appearing anomaly. It is there always, but we may not be able to diagnose even the base of the hand. So so always we talk of the sensitivity diagnosis with me or anybody else. If I diagnose Mayank miss karu, मैं pick up karu. No big deal. Please.
One should not broke the eyes for finding isolated VSD.
सुमन समझ नहीं पड़ी.
One should not broke the eyes for
Yes, definitely. So as we are skipping a few cases because we are running off time, this is one of the borderline ventriculomegaly we want to discuss. Or if you don't, then we can move on.
Just
took a collective deep
so, third case, please.
Third trimester. We are moving on one case. I feel this is which I want to share. If you want, you allow me, then ventriculomegaly, I can go back. It's fine.
Yes, first we'll finish this, then we'll go back to that.
So if we have a time, we can go back and discuss that cases. This is a 34-year female, primary IVF conceptions. First trimester screening was normal. Second trimester TIFA scan at 20 week was almost normal. Both done by fetal medicine specialist. This is even done by me. The all growth charts were absolutely in a normal range. Patient was sent for a growth scan at 30 week of pregnancy. And these were the findings when I start scanning of that patient.
So actually, this was a patient, 11 to 14 weeks scan done by me, absolutely normal. Anomaly scan, Mayank bhai, absolutely normal. And growth scan, Dr. Ripal. And these are the findings.
It's more than 99 centile. More than 99 centile.
BPD and SC, head size is almost more than 99 percentile. Then can you see the, yeah, please sir.
Bossing was there.
Please, panelist, yeah.
Microcephaly was there and A5 was high, polyhydramnios, A5 was 29.
Next, please.
Yes, so I go on long bones and all long bones were less than 1 centile. all were around 24, 25 week of pregnancy. Femur-foot ratio was 0.7. And this was the chart when I saw all long bond was fell less than 1 centile from as compared to the previous TFA scan.
So can you show me the when I'm doing the second trimester anomaly scan femur percentile?
Yes, sir. So, femur.
31, what is the percent?
It was a 20th centile, sir.
So the question is this anomaly missed at 20 weeks anomaly scan or 11 to 14 week scan? And
Anybody wants to comment on the diagnosis and how?
So how to proceed with this patient? And the doctor, referring doctor.
And the patient.
And the patient.
The patient. Yeah, please.
So if you can just cycle back 2 slides. So one more slide back, please. Ek aur. Sorry. So retrospectively, first time when we all saw this, we felt this is normal. But if you see that tiny ratio at the bottom, the BPD FL, that looks a little
So that
off.
was retrogradely I found
Yeah.
when I went back to my
So
parameter.
sometimes we look at the measurements, but we need to learn to look at the ratios. I don't still do it. It's something that I still need to learn. We all have to keep learning. But maybe we might have suspected it. Again, we could not have diagnosed it. So if you ask me the question, could you have diagnosed this before? No. Diagnosis, we could have only suspected or maybe followed up the patient a little bit earlier. But yes.
One more thing which I found retrogradely, the humerus was on 10 centile. So HL length, and I went back and I checked the humerus length, but that was not like femur is the most.
In this case, if you see the BPD FL is higher side, but BPD, if it is a brachic FLE, it will be low. Say then.
Patients,
It may not suggest the
mother's head size was very big. at that
skeletal
time.
dysplasia.
So,
So this is a very
Yes, sir.
technical term not to be discussed with all those obstetricians. Go ahead.
No, so the thing is that it's not kind of a anomaly was present. Means this was turned out to be a kind of
Late appearing.
skeletal dysplasia. So anomaly was present right from when the sperm has met the ovum. So the embryo formation has been with the anomaly, but still it is a kind of what we call the late onset anomaly or evolving abnormalities. So any suggestions for a late involving or
let me
abnormal?
follow up. We'll finish the follow up and we can discuss about the late evolving. Baby delivered and post delivery, the mutation was confirmed. It was a non-lethal skeletal dysplasia, achondroplasia. FGFR3 mutation was confirmed post delivery. So, do we have a list of evolving anomalies that can appear in the 3rd trimester? Yes, we have. And do we have any findings in the TFA scan from which we can suspect there might be a chances in this case, chances of developing late evolving anomalies, and we can make a follow-up of this list we can discuss.
Most of the times it may not be possible to have any suspicion at the time of 20 weeks anomaly scan. It is only during the follow-up that we may find this, because the diagnosis depends on.
So how far we reassure the couple that at anomaly scan that yes, baby is normal? Because the simple question is
દેખાય છે બરાબર છે.
Okay.
And this is not 100%.
So are there any, we are statistical people now, okay? This percent of chances of rain. So is there any something there
We
percentage?
say 80%. We say 80% we can diagnose the anomalies. We cannot diagnose 100% of the anomalies because the brain develops even after birth of the baby. So till 5 years. So we cannot predict and diagnose those
Few
things
cases
at
are
early
there.
stage.
The anomaly scan, we have to explain the patient that all the deformity we cannot detect at this time.
Yes, ma'am.
Something is possible that we cannot detect.
So that is in our slides.
Say possible something.
Very true. Very true.
Otherwise, the advantage to animal scan patient will be happy. There is no problem.
Because patient's question is બધું સારું છે આપણે કે જેટલું દેખાય છે એટલું સારું છે અને this is not 100%.
So that counseling part is very much important. I want to just first finish up the things. This is one of the database 2024, and they have just describe if you will do a first and second trimester combined good protocol based scans, you can rule out 83% of structural abnormality, and if you will do only a second trimester, 50% of the abnormalities can be detected, and if you will go only for first trimester, it's 37.5%. So now the first trimester scan, it become a part of your ruling out of congenital structural abnormalities. So first trimester scan is not only for the Down syndrome, you have to include in your checklist to rule out a major structural abnormality also. Then what about the remaining 16%? That has been discussed. There are certain abnormalities may evolve and may appear in the third trimester, like non-lethal skeletal dysplasia, microcephaly, lysencephaly. There are certain brain abnormalities are there. There are certain abnormalities which, despite of meticulous scanning in a first and second trimester, you may diagnose after delivery. Light finger abnormalities, ear abnormalities, isolated cleft palates, small VSDs, imperforated NS, and despite of all normal scan, there might be a possibility baby have some genetic syndromes post-delivery.
Okay, so that at least we can say that 80 or 83% or 84%, or if the patient is thin, lean, machine is very good, and I'm looking at the first patient in the morning, then say 85% I can reassure.
So it depends
But
on
15% is always in the hands of somebody else, higher consciousness, and that's what we have to tell the patient, that yes, your baby is fine, but at this comfortable range only, and we absolutely need a 7-month or the 28 to 30 week scan. Please.
Yes,
So
that's
it should
what
be
I was trying to
incorporated
say.
in your
please,
That
please.
NT scan, anomaly scan, please add an additional 28 to 32 week scan
30.
before the 36 week growth scan. That
So
scan
one
is
add-on
needed.
growth scan, ideally it should be around 30 week or 32 week of to check for the late evolving anomalies and specifically early onset FGR. These are the two things which we might pick around 30 week of pregnancy.
Any dignitaries want to add anything, please? Or we are ending the session.
Practically, are the patients and the obstetricians ready for this? That is one thing. I think we should
Might be we
sensitize
need-
them for this.
Might be we need to sensitize the patient more. That's what, as an obstetrician, what I feel. Whenever you counsel patients in that way, these are the options, and you can give an option. Many a time patient turn up for the growth scan also. That's what I feel.
See, I think continuing on the lines what Sir said and Jigish Sir said, for obstetricians, to make it a very simple formula, if you do a dating scan and if the pregnancy is corresponding to the patient's LMP, 3 months from the LMP is around 12 plus 5, 12 plus 6, that is when the NT scan, the CRL would be good enough. 5 months from then would be 21 plus 4 or 21 plus 6, that is the time for the anomaly scan, and 7 months from then is around 30 weeks, that is for the late anomaly and early FGR scan. So 3, 5 and 7, if you just keep this in mind, as long as the dating is matching to the LMP, this will make life very simple. You can just look at the LMP and give them, ये date को आपको ये scan करवाना है, ये date को ये scan करवाना है, and your pregnancy would be sorted.
Okay, thank you everybody. Thank you AOGS team, Dr. Munjal bhai and Dr.
You want to discuss Ventricular megaly? Should we go back?
We will have during the live lunch. Please, the most important thing that we have not discussed is introduction of our esteemed panelist. So please, one by one, please introduce yourself, please. Sir, please. Janak sir needs a very big introduction. He is Janak sir. Please.
I will maybe take the privilege of introducing him. Teacher for almost all of us, very, very senior and our most respected and expert fetal medicine specialist, Janak Desai sir. Thank you so much for supporting us.
Please, please, everybody, please.
So I am Devang Patel. I am maternal fetal medicine specialist. I am working at Divine Women's Hospital and Meringo Sims Hospital.
I am Dr. Viral Pandya. I am a fetal medicine specialist and I am practicing at my clinic Fetus at Nehru Nagar.
I'm Dr. Devanshi Shah. I'm currently working as an assistant professor in LG, and I'm also a maternal fetal specialist.
Please.
I'm Dr. Bhumika Shah, and I'm practicing at Anand, Gujarat.
I'm Dr. Forum Acharya and I practice at Paras Advanced Center for Fetal Medicine.
I'm Kanan Kotdala. I'm as a maternal and fetal medicine specialist at Kotala Hospitals.
I'm Dr. Riddhi Mehta. For a decade, I was a fetal medicine consultant, and now I am practicing obstetrics as well in Sarvamangal Women's Hospital. Sitting in a one black room and doing scan from right.
So I will introduce all. Yes, ma'am.
She fetal medicine as a consultant, I don't have the.
That's why I'm asking from gynec she turned up to fetal medicine.
But obstetric practice is a much more joyful than the fetal medicine as a consultant.
That is definitely.
Yeah.
And the reason.
So I want to introduce all these 4 and 3, 7. Believe me, they are doing better than me as a fetal medicine consultant and anything else. They are one of the most efficient and very promising fetal medicine consultant of Gujarat.
Sir, હું રહી ગઈ.
GGS is the most senior most fetal medicine consultant, highestly recognized and respected.
Oh, please. Thank you so much.
I just wanted to ask one question that I think you can also answer. What can we counsel about autism spectrum disorder? I don't know, it is my luck or everyone is getting that, but it is like 4th or 5th patient in last 3 months. They will say कि
So this is a good question. This is a good question, and this is we are come across this from the obstetrician's point of view, because they have the mother having a child who has autism. So please remember, autism is a multifactorial. It is not only genetic. So counsel them. So that is I am coming to your point. Counsel them that unless it is index cases. Genetically done, then only you can. And then genetically, if there is a positive, there is genetic, then there is indication of any invasive and you can help, otherwise not. So that is the counseling part. Unless the index of autism child with the mother has, and that child has gone to the genetic test and something is positive, then we can help as a fetal medicine consultant by either Korean biopsy or amniosis. Otherwise, we cannot help. That is the answer, and counseling should be done.
Yeah, just one thing to add. Or in many autism spectrum disorder babies, so the so-called autism babies, we need to do the whole exome sequencing is those live affected child first. That's what the sir has told. That is very important, because many a times out of 1 or 2 out of 10, we are getting a rare disorder or mutation or some syndromes. Although it might be the rare or may not be recurring, it is better to always to counsel that for next pregnancy at least we can offer the amniocentesis.
So, and that is not only true for autism, it is true for any genetic disease. Unless index case is positive and you are investigated, then we can help very properly. Otherwise, you have to go for trial, means when you do amniocentesis and take this, that will be the costly affair. And that.
If the child is male, then add Fragile X syndrome also in investigation, because that will not cover in exome sequencing.
That is one of the most. So Fragile X is one of the commonest low IQ baby. No, not there. No. It is simple answer.
Even
if it is there, then everybody do whole exome sequence too. If somebody is affording enough and they want to take his whole exome sequence, but there is an advantage and disadvantage. Our genetician can explain you. So there are.
The question was very simple. If I expense for the WES, is there any guarantee? Patient always asks for the guarantee. Is there any guarantee that my baby will be congenitally, genetically normal?
No, your answer should be no, right? You know also no. So I say કે તું અહીંયાથી રસ્તો ક્રોસ કરીને સામે જવાનું તું જીવતો હોઈશ તો તને ખબર છે guarantee no. That's it.
Can we continue the discussion post lunch? Yes. Yeah, can we call?
Mike?
Suppose the patient comes at 22 weeks with skeletal dysplasia, and suppose the patient comes to us in 22 weeks. What is the difference at the age we detect, suppose at 26 weeks and at 22 weeks? Now at the 22 weeks we can go for termination, but at the age of 26 weeks in skeletal dysplasia case we cannot go for termination. So what are the fetal rights? Are there any fetal rights? Suppose the couple tells that we want to terminate the this at 22 weeks.
So there is a moral issue, right? So in advanced country they talk of as a fetal right. At present, in my last 30 years of fetal medicine practice and 45 years of my gynec practice, obstetrician practice, I have not think of fetal rights at present because it is not practical in India at present. આખું બધાને કન્યાને કેડે ભાર છે પેશન્ટને not only expense of rearing the child. Suppose Down syndrome, that Down baby also have the fetal right to live. You can argue, but burden of to the family, to the society is too much. So that then you can talk of fetal right. At present in India, it is relevant.
Thank you so much, sir. Now we would like to conclude the session and further discussions can be carried forward during lunch hours. We would like to invite Dr. Alpesh Gandhi, sir, for felicitation of moderators and panelists, please. Thank you. Thank you. Dr. Ripal gave.
Dr. Ami Mehta, madam. Dr. Devanshi Shah, madam. Wala, ma'am. Dr. Riddhi Mehta, madam. Dr. Riddhi Bhatt, madam. Dr. Forum Acharya, madam. Dr. Viral Pandya, sir.
रिद्धि भट्ट નથી આયા रिद्धि भट्ट નથી આયા
Dr. Viral Pandya, sir. Dr. Devang Patel, sir. Dr. Janak Desai, sir. And Dr. Bhumika Shah, madam.
Can we hear all of us on stage, please, for a group photo?